Hey everyone, this is Dr. Matt with the Ethos Athletes Podcast, and today we're doing our second episode in our sleep series. Today's episode is Common Reasons People Lose Sleep and How to Fix Them. And for this particular series, I brought in Dr. Troy Anderson, who is the owner of Phoenix Neurology and Sleep Medicine, which is one of the largest privately owned clinics here in Phoenix and the largest privately owned sleep clinic in Arizona. Dr. Anderson is board certified in neurology, sleep, and bariatric medicine. So, Dr. Anderson, welcome back to the show.
Thanks for having me back again.
So today we're going to, as I said, we're going to be discussing common reasons people lose sleep and how to fix them. And in our last episode, if you haven't heard that, you should definitely go check that one out. We discussed basics of sleep and talked about the sleep cycle and talked about the benefits of sleep as well. So, Dr. Anderson, obviously, I think, as we mentioned in the last episode, there's a lot of people who struggle with their sleep. How can they find out if they have a sleep problem? Is there any kind of test that can be done, either in clinic or at home? And let's start with that. So, aside from being tired throughout the day, how else can someone determine if it's actually a sleep problem?
Well, you mentioned that in passing, but that is actually the first step in seeing if you have a sleep problem is if you're tired in a day. So you shouldn't be tired throughout the afternoon. It's okay sometimes, maybe take, like I talked before last segment about taking a power nap. But for the most part, you should be able to engage and be productive throughout the day. Now, it's common, maybe 6, 7 o'clock at night when the sun goes down, the patients get tired and they can struggle to stay awake. But that's probably more natural. You probably should go to bed like 8:30, 9 o'clock anyway. But if you're tired in the afternoon, that's a sign that you're having an issue. The other sign that you have an issue is people around you. So we commonly will get complaints from patients' bed partners that would complain that somebody's like snoring, or they're witnessing that they have sleep apnea, or they're sleepwalking, or they're doing these abnormal behaviors in the middle of the night. Those let's not discredit them, because I see that all the time. That I don't do that. And so the spouse has to record it, for them to do it. And then when they come in and they show me this videotape and they saw this guy that's completely like choking and not breathing for 2 minutes, and that's what they finally took for them to come in and see me.
Okay.
So, and I get a lot of patients will go to the hospital and be witnessed by hospital staff, doctors and nurses that will see things, and that'll set them off to see me.
Okay.
But so I see patients for a variety of reasons. I see them because they can't sleep at night. I see them because they're tired in the day. I see them because they're doing abnormal activities at nighttime. Those are probably the top 3 causes. So we call that insomnia, hypersomnia, and parasomnia.
Okay.
Those are the 3 things. Now, we do have tests to see if patients have an issue, because the most common reason why patients have issues in today's day and age is sleep apnea.
Okay.
So sleep apnea, when I first came into sleep in, let's say 90s, it was underdiagnosed. We've done a much better job now of diagnosing it well. We still have a lot of patients in denial, but I think for the most part, it's become more accepted to wear something at night. And patients are now talking about it, and as they're talking about it, it's been more accepted, and so patients will come in and be seen. But the test we have the home sleep test, and we have the in-facility polysomnogram test. Okay. We have something we call a split test, where we do both the diagnostic test and the CPAP titration portion of the test. And then we have something called the multiple sleep latency test that helps us determine if they have narcolepsy. And then we have something called the mean wakefulness test. So those are all our tests in sleep.
Okay.
The home test is really reserved for the healthy patient that we suspect has sleep apnea, and we're trying to screen to see if they have sleep apnea. That's really the only thing it can detect is sleep apnea. So you're doing these tests for sleep apnea patients that are relatively healthy.
Okay.
If you have a patient that has cardiovascular disease or maybe stroke, or that we need to keep an eye on them a little bit closer, then we'll bring the patient in.
Okay.
And those patients will have an in-facility study called the polysomnogram test.
Okay.
Now, often, if I suspect that somebody has pretty bad disease, I don't want to delay their treatment. So I will order a split test because I want to diagnose them as quick as I can, put them on treatment within a week or two, and get them going. Because if you do just a diagnostic test, you may not get them back in for 4 or 5 weeks. Read it another week or so.
Okay.
We might not know what's going on until 5-6 weeks from now, and then giving them treatment could be another week or two as we work through insurance approval.
Okay.
So I'll go order a split to speed the process up. Mostly the majority of what I do is order splits because I'm trying to minimize patient time into my clinic and maximize them getting treatment as quick as possible.
Okay.
So, and then the multiple sleep latency test is a test that after you do the night test, you do the multiple sleep latency test, and what you're looking for is if they're if they're unable to stay awake in the daytime despite a good night's rest. And that's when we can diagnose narcolepsy and the hypersomnia disorders. Okay. We look for some patterns. They're falling asleep right away. If they're going to sleep each time, they shouldn't be. They had a good night's rest. They shouldn't be falling asleep right away. And they shouldn't be, and one thing in particular is they fall into dream sleep. They shouldn't be falling into dream sleep. And if they have it twice, that's diagnostic for narcolepsy.
Okay.
So, and then the last thing is something called the mean wakefulness test. And what that does is, somebody is trying to prove, let's say, to a job or employer or to get their certified driver's license that they're well treated and that they're no longer tired. So somebody, let's say with narcolepsy that I have on medicine is trying to get a job, but they need proof that they're not falling asleep, and so they'll do this mean wakefulness test to prove that all day long that they're not falling asleep.
Okay.
So those are sort of the 5 tests that I have to help me diagnose if somebody is having some sort of sleep pathology.
Okay. And when they go in for into the clinic to do a sleep study, is it like what you see on TV in the movies where they're hooked up to wires, and what does that process look like?
Yeah, it's true. It is like that. So they come in around 7:30, 8:30. They get hooked up with wires, and we actually can see them through an infrared camera. But our wires on them give us a lot of information. So first of all, we have EEG leads to help us determine what sleep stage they're in. One of the stages that we talked about in the last segment. We have eye leads to tell us the rapid eye movement that helps us classify the stages of sleep. We have flow meters in the nose and mouth to see if airflow is happening. We have EKG leads to see what their heart rate's doing. We have these belts around their chest and abdomen to see if their lungs are expanding and whatnot. And we can infer so many different things from that. We have leads on their legs to see if they're kicking or whatnot. And then we have an infrared camera on them so we can watch what they're doing throughout this process. So when you combine all that data, we can diagnose a lot of things, like something called periodic limb movements in sleep, where you're moving your legs at night and it's waking you up. You can diagnose sleep apnea, where you're not having any flow in your mouth and nose, even though your chest is expanding. And then you have central sleep apnea, where there's no flow and your chest isn't expanding, so there's no initiation of breathing. So there's a bunch of different things: seizure, cardiac arrhythmias.
Okay.
We have an oxygen meter to tell if they're what their oxygen level is doing throughout the sleep. So we get a lot more data in the facility. So for most sleep physicians, we prefer that, because we want as much data as we can, and we're trying to figure out why patients aren't getting a good night's rest. We want as much data as we can.
Okay. Now, obviously, on a much smaller scale, I know that there are patients that I have, or that there are people that ask me if something like a Fitbit, Fitbit exists, and I know that tracks sleep, and I'm doing air quotes for that. 'Cause, there's also, I've seen like different mattress pads that record different things. So how when someone's interested in, am I having a sleep trouble? Sometimes these are some of the first things that they turn to. How accurate are those? Is there one, if you do prefer any, is there one that you prefer over the other, or
Sure. Well, so first of all, I would tell you. So in terms of this is a good tool. It can be a good tool in the sense of, if you are like sleeping well through a period of time, let's say 2 or 3 months, and you look at that data and you look at it and say, okay, this, if I'm going to bed at this time and waking up at this time, and this is my percentage of what it's saying is deep sleep and light sleep, and I'm feeling good and well rested, then that is normal for you. And then when you're having a period of when you're feeling like tired in the daytime, and you take that set of data and you compare the two, then they can infer that there's a problem with how you're sleeping. You're not sleeping like you used to. But to look at that data, which is what I get, and patients say, I'm not getting enough deep sleep. You cannot determine if you're getting enough deep sleep or light sleep or whatever type of sleep just with something you wear on your wrist at all.
For sure.
So it's very inaccurate for that. And so, patients, I'm not getting any sleep at all. Well, we all know from the prior session that if you're not getting sleep, you're probably going to die, from it. So you're obviously getting some sleep, because they'll say, I haven't slept for a month. Well, you're probably getting some sleep, restorative sleep, just enough to, keep you functional, keep you alive. Maybe it's not 7.5, 8 hours. Maybe it's just maybe little cat naps here and there that sum up to maybe an hour and a half, 2 hours, but you're getting some restorative sleep.
Okay.
So I think that's these Fitbits and things like that, there's not one better than the other, but it's more important that you compare a season of good sleep to a season of bad sleep if we're trying to figure if there's something wrong with their sleep pattern.
Okay. And I think that's a good distinction to make too, because I know, and maybe you can speak to this, or you kind of mentioned this a little bit, where I think there's a psychological component too, where if the Fitbit says that I didn't get good sleep, patients believe that they didn't get good sleep, and they get really stuck on that. I don't know if you've seen that in your practice.
Yeah, it happens so much, and if physicians get that way too, because what we'll do is we'll treat the numbers and not the patient. The patient's not complaining, they're happy, they're using the machine, but we'll look at these numbers and we're like, why are these numbers off? And then we do all these things try to treat the patient and make them so uncomfortable. And, but the patients are sleeping well. We do overnight oxygen tests on them, and their oxygen rates are over 90%, but we're treating these numbers because they don't look right for us.
Right.
And that happens all the time, where patients can look at the numbers and then feel like they're not getting good rest even when they are. And a lot of patients, as you and I know, have psychological issues with anxiety, and that just opens the door for letting their mind just go crazy. And now they get something called psychophysiologic insomnia, where now they get scared of sleep, and once it's time to sleep, they start getting more nervous and more anxious, and sleep becomes the complete opposite of what it's supposed to do, which is supposed to get you to calm down, rest, relax. And now instead you're scared of your bedroom, and you're scared of sleep because you're scared that you're not going to be able to sleep. Okay. It's really quite interesting. So we need to be careful, and we need to have good psychological defense mechanisms to just sometimes let things go, and focus on just relaxing and tuning out.
For sure. And so that kind of leads me to the question of what are some of the causes of lack of sleep, or one of the problems that can cause lack of sleep. And I know we'll get into a few of them, but one of the ones that I did want to ask a question on was that mindset of, I have a lot of people that come in and they'll say, my mind's just constantly racing, or I can't shut off my mind from what happened in the day, or what I need to do tomorrow, or whatever it is. How often do you see that, and how often is that a factor in lack of sleep? And
I see it all the time. I see it when it comes to, so you asked what are some of the things. So let's talk about insomnia. Insomnia is definitely one of the most common causes of patients of complaint. In fact, I would have to say probably everybody's had insomnia at one point or another, but it's not pathologic because they get good rest and they recover from it. When it becomes pathologic is when somebody's having chronic insomnia over time, and it's starting to affect their ability to their function in daytime, and they're getting tired. But probably the most common cause of insomnia today is anxiety. Okay. So patients get quite anxious over things, and they think about things over, and they don't. It's hard for them to understand that you're not going to solve problems after 7 o'clock at night. Right. Right. And so I try to train my patients, that after 7 o'clock at night, you can't do anything really to improve the situation. You can't talk to your the police or the attorney or, your doctor, For sure. You can't, if you engage in a conversation with somebody, you're not going to probably resolve issues, when you're tired and fatigued. It's really time for you to just kind of come together. In fact, my daughter, she last year, she didn't do well on one of her tests. Okay. So I came home late that night, and it's 8 o'clock at night, and I was like, sweetie, you didn't do well on your test tonight. And she was like, Dad, you can't talk to me about that stuff after 7 o'clock at night. I can't sleep. And that's the kind of mentality we need.
That's really cool.
We need to just not talk. And that's my rule. And she turned around to me and she's absolutely correct. We can talk about it in the morning when she's fresh and we can actually think right. She's not willing to think right. You imagine everything that we go throughout the day. I mean, you wake up, you have to work out, then you have to do this, and then you see your patients, you're a doctor, or do your work, and then you meet people, emotion. How many people or conversations have you had? How many words have come out of your mouth? How many words have you heard? And then at nighttime, after you have all this input and your head's going crazy, that's the time for you to try to work things out.
Yeah.
That's not the time for you to work things out.
Okay.
It's better for you to just let that time, let your brain recover, come back to it in the morning when you're fresh and everything in your brain's emptied out, and you can attack things and think about it clearly. And I'm sure you and I probably know multiple times, in the middle of evening, you're not thinking of it as clearly or as insightful as you are when you're fresh in the day.
For
so
sure.
Insomnia definitely by far, and allowing the world to come in and penetrate our evening is probably one of the biggest sources of it. And then on top of that, if you have anxiety, if you're prone to be a worry person, an anxiety person, it's really hard to let go after 7, and you really need to work on it, because as soon as you allow yourself to take that forbidden fruit or after 7 o'clock start thinking and worrying about things, it will consume you all night long and you won't get rest. And the next night you'll be just worse. So we really need to compartmentalize. The second thing that we see a lot of is sleep apnea. So insomnia is one, and we're going to talk about in the next segment about sleep hygiene and that sort of thing. But in terms of disease process, the second most common thing I see is sleep apnea. And sleep apnea, as I mentioned before, is a condition when we're sleeping, the muscles relax in the throat, causing the airway to close. And so essentially, it closes so much that you're not able to oxygenate the body.
Okay.
And so it's almost like if you're choking on a piece of steak, except for it's your excess tissue. And that could be quite severe, because if you're not getting oxygen in the system and it's for a prolonged period of time, depending on how severe it is, you can suffer from a heart attack, stroke, or even die from it. So there has been 2 people that have died in my career that I've seen from sleep apnea.
Oh, wow.
Very famous football player, Reggie White, died from sleep apnea because he choked in the evening.
Okay.
And so it's very common. You don't have to be obese. 60% of patients with sleep apnea are obese. 40% of patients that have sleep apnea are actually thin.
Okay.
It's all in the way the oral pharynx is formed. You can have a small jaw, or who knows, you can have large tonsils. You could be a football player and just have a lot of muscle.
Neck muscle, yeah.
Yeah, so there's a lot of different things of why you can have sleep apnea. But the bottom line is, if you're not getting air in your system at night and you're not aware of it, that can be for a prolonged period of time, and you can die from a stroke or heart attack from it. There's other complications. The other complications with sleep apnea is when the brain thankfully recognizes that you're choking and it wakes you up, the brain is waking up and it's not getting the rest that it needs. These are called microarousals that last around 10 seconds. So you don't know you're waking up, but it's enough to take you from maybe one of your deep restorative sleeps from stage 3 to a stage 2, stage 1 sleep. And now you're not completing a good cycle. Your sleep is fragmented.
Okay.
And so there's a lot of implications to that. If the brain's not getting recovery, you're going to be tired in a day. Studies have shown that if the brain doesn't get recovery, then you're at a 3 times increased risk of Alzheimer's disease from it. And then other things happen when the brain recognizes that it's not getting rest. The adrenaline goes up. Like if you're choking, your adrenaline goes up. If you're choking in the middle of the night, your adrenaline goes up. Adrenaline causes the heart to beat faster, the blood pressure to go up, glucose to be released in the system. You can overwork the heart, putting you at risk for heart failure, developing cardiac arrhythmias. You can develop high blood pressure over time, or diabetes over time. So sleep apnea is another huge condition that we see very commonly in today's society, especially with the increase in obesity and that sort of thing, because 60% of it is from obesity.
Yeah.
So there is a huge growth in sleep apnea. Sleep apnea and insomnia can actually cause weight gain, as we talked about in our last segment.
Right.
So, so getting a good night's rest, finding out if you have an issue, if you have tiredness in a day, if you snore, you need to come in and have us check you out for sleep apnea.
Okay. Now, does sleep apnea have a demographic in the sense that like can it affect people of any age, or is there a certain age range that
it can really affect any age? And so I take care of kids usually, but it's different mechanisms. So in a child, mostly it's tonsils, and the treatment's tonsillectomy.
Okay.
Where as an adult, a lot of it, like I said, 60% is from obesity, but 40% isn't. So there's different mechanisms.
Okay.
Yeah.
Okay. So we talked about insomnia. We talked about sleep apnea. What's another cause for people to lose sleep?
Yeah, so I mean, we talked about this a little bit as well as bad sleep hygiene, and so they allow worries and that sort of thing. We see that quite often. And so we're going to talk about in the next segment of what you can do to make sure that you have a good sleep hygiene and prepare for sleep. Because I don't think in today's society, we've allowed all these stimuluses to come into place, and we've forgotten how to be bored. We've forgotten how to rest. And we need to remember how to do that.
Yeah.
Yeah.
Okay. And then before the show, we also talked about external factors being one. So that would be like medications, caffeine. To talk to us a little bit more about that.
Yeah. So, there's a ton of medicines that cause daytime sleepiness. And so that's one thing that you have to be very cognizant of, is that medications like gabapentin, some of the antidepressants, narcotics, a lot of benzodiazepines for anxiety. A lot of medications cause daytime sleepiness. So if you're sleeping in the daytime, make sure it's all about timing. If you start a medicine, you're tired in a day, be cognizant of that. That could be one of the reasons why you're tired. Also, medications can cause insomnia at nighttime. Many medicines cause insomnia. And so that could be another reason why you're doing it. So you got to make sure that your primary care physician is kind of aware of the side effects you're having, and is kind of making things conducive for sleep. So some medications, for example, Topamax, if that's taken in the daytime, is making you tired, but that's used for headaches quite often. But if you take it at nighttime, then you fall asleep through it. So you can be more insightful and judicial on what time you take medications. Will help work with your sleep cycle.
Okay.
So that's good. And then caffeine's a big issue, I mean, I've seen people come in and, I ask them, how many cups of coffee you have? And they say 1 cup. I said, that's not bad. And then they showed me like a 64-ounce big gulper, I mean, it's it's, caffeine is a stimulant and is a sleep blocker. And so we have to make sure we control our caffeine intake. It could come from in a form of sodas. Teas, not so much because it's not that much, but some teas for sure, especially in the middle of the night. Some teas are good, like chamomile tea is asleep, helps you fall asleep. So it depends on the type of tea for sure. But, chocolate can cause nightmares, a whole host of things, and the best way for you to figure out how something is affecting your sleep is by just being aware. You take something and then following pattern. Every time I take this, I have nightmares. Well, that sort of thing. Or I just started this medicine and now I can't sleep at night. Those are the kind of things you have to be aware of it.
Okay. Now for
one last more, smoking.
Oh yeah.
I had to mention smoking.
Yeah.
So smoking's a big one too, because a lot of patients smoke, and what the smoking does is it causes cravings in the middle of the night, and that wakes you up.
Okay.
So I know a couple people, I have a few patients that smoke and drink a lot, and they're up all night long. They need to wake up at 4 o'clock in the morning for their smoke and their alcohol, because otherwise they get the DTs and, the cravings. So they're up what time they're up and out of bed all night. They're not going to bed at 12:30 or 1, then they have to wake up hour and a half, 2 hours later so they can have something. So it's alcohol and smoking can cause insomnia.
Okay. And alcohol causes cravings as well?
Oh yeah.
Okay.
Yeah, they need to wake up early to have to treat their DTs.
Okay.
Yeah.
Going back to caffeine, is there a certain amount or like a max limit that you tell your patients don't do it this time, and then or don't do this much, and then is there a time limit that you say don't do it after this time in the day?
Absolutely right. So I just tell them to take 1 or 2 cups of coffee, and not to take it after 2 o'clock in the afternoon.
How big is a cup?
Just a normal cup.
The normal,
yeah. I don't know how big are those cups. 6 ounces,
6 ounces,
maybe.
I think,
Yeah, probably. Yeah. Yeah, 1 to 2 cups. Too much coffee, you can have. It's interesting. You can have migraines with too much coffee, but the chronic coffee drinkers drink 1 to 2 cups for years on end. If they don't have a cup, they'll have a migraine. So it's going to be quite interesting.
Okay. so that we discussed, again, sleep apnea, insomnia, bad sleep hygiene, which we're going to talk about sleep hygiene in the next episode, and then external factors. Now, one of the things that we also discussed before the show is that there's a difference between sleepiness and fatigue, correct?
That's right.
So can you elaborate a little bit more on that?
Yeah, for sure. So sleepiness is like actually falling asleep and being like, tired. Like your eyes are heavy, you're having a hard time keeping your eyes open. If you do keep your eyes closed, you lose consciousness because you fall into the sleep realm where you're having a reduction of sensory input. You don't like hear, your audible hearing goes down, your sensation and touch goes down. Those are sorts of things that tell you that you're falling asleep. You're this removal from the environmental stimuli and your senses being dull. That is sleep. Fatigue is something different. You still have all those senses in place, but you don't have energy. So where sleep is is a state of consciousness.
Okay.
Fatigue is a state of energy level.
Okay.
Right? And so if somebody says that they have a fatigue, sure, somebody who has lack of sleep is going to say that they're tired or sleepy and they're also fatigued. You can definitely have that. But to split that out separately with fatigue is lack of energy specifically, like weakness, they're just laziness, they're feeling like they're not unmotivated. But they're not like, they don't lay down on a chair and lose consciousness and fall asleep. They may because they're bored, but that's not the thing that's driving them to the couch, because if they don't get on the couch, they're just going to fall over from falling asleep. Okay. They're going to the couch because they have lack of energy and, and unable to do things because they don't have the strength and stamina. So strength, stamina, and that sort of thing is more for fatigue. Falling asleep and losing consciousness, losing that sleep episode where you're not listening and hearing and reduced tactile sensation, that's sleep.
Okay. Yeah. Cool, perfect. Is there anything else that you'd like to talk about before we wrap up the episode on reasons people lose sleep?
Yeah, I mean, we're going to talk about a lot in the next segment, because sleep hygiene, I think, is it's such a... Every time I go out to dinner a lot with a lot of different people, and as soon as I say, yeah, I'm a sleep doctor, and that's pretty much what I do. We always talk about sleep, and sleep hygiene is probably what it almost ends up going to. Okay. Because society is, they just don't know how to do it.
Yeah.
And I think so I think the next segment, I think we're going to talk about, is really going to get into a full day and how to prepare for sleep.
Awesome. I love that. Yeah. Perfect. Well, let's just go ahead and summarize today's episode. Again, we talked about common reasons people lose sleep and how to fix them. And in this episode, Dr. Anderson mentioned that if you're having trouble sleeping at night, if you're tired throughout the day in the afternoon, or if someone tells you that you snore or that you may have sleep apnea, then those are reasons to go in and get tested to check to see if there's something more going on as far as what could be affecting your sleep, and to help properly diagnose what's going on so they can get you back to getting good sleep. And then we also mentioned a few different tests, which you can go back and listen to as far as some of the tests that Dr. Anderson does in his office. Now, reasons that people lose sleep, we mentioned insomnia being one of them, and anxiety being one of the drivers of insomnia. And one way to help fix this is just to do your best to compartmentalize your life and learn that after 7 p.m., whatever happened throughout the day, there's really, or whatever's going on the next day, there's really nothing you can do about it. You can't go and call most people. If you have some business to do, or if you need to talk to a doctor, or lawyer, whatever it might be, those people are not available after 7 p.m. in the majority of the time. So just to understand that this truly can wait till tomorrow, and that will ideally, work to kind of decrease your stress and anxiety and allow you to sleep better. Another thing that we mentioned was sleep apnea. Now, this can happen in both young individuals and older individuals, thin and overweight. There's a number of different reasons that this can happen. Again, this is kind of when when you're told that you're gasping for air or choking at night. So that if you think you're experiencing sleep apnea, definitely get tested and take a look at that. We talked about bad sleep hygiene, or we mentioned bad sleep hygiene. We're going to discuss that a lot more in the next episode. And then we also talked about external factors such as medications, caffeine, alcohol, smoking. Those are all things that can prevent you from sleeping. And chocolate as well. I forgot about chocolate. That can cause nightmares. If you do consume caffeine, stick to about 6 ounce cups, or stick to 6 ounce cups, no more than 1 to 2 cups a day. And then definitely don't do anything after 2 p.m. Or else that will end up keeping you up at night as far as caffeine intake goes. And then Dr. Anderson also mentioned a difference between fatigue and sleepiness. And fatigue is a state of consciousness sleepiness is a state of consciousness that you go through where you start to lose consciousness, whereas fatigue is having low energy, weakness, laziness. You could be unmotivated and you have decreased stamina. And I'm assuming that sleepiness can lead to fatigue throughout the day, correct? Or
absolutely,
lack
they're
of
connected.
Sleep can lead to fatigue.
Yeah, they're connected. That's why it's really hard to distinguish the two. So there is connection. One can lead to the other, but there is a difference.
Yeah, absolutely. And so, I think we threw a lot of information at you on this one, and hopefully you were able to take a lot away from it. Our next episode will be discussing ways to improve your sleep and your sleep hygiene. We'll have Dr. Anderson back on for that one. So as far as today, Dr. Anderson, thank you for being on the podcast again.
Thanks for having me.
And we'll hope you enjoyed the show, and we'll see you on the next episode.